This program is brought to you by Emory University.
All right, good morning, everyone. Welcome to Cardiovascular Grand Rounds for Real. And just want to start off with a reminder, we're at the end of our drive for CASA for the kids campaign for the holidays, and we're, as usual, a little bit short as coming into the home stretch. So keep those kids in mind. We sent out some emails, and for those who don't remember, CASA is the court-appointed special advocate that works with Fulton County court system to help out kids who have either been removed from their homes by the court system or been abandoned by their parents to the court system. And we take some donations through a PayPal link, and basically we go out and for each kid buy usually some clothing and toys, things like that, some things to get them through the season. And really appreciate everyone's generosity in the past, and we're hoping to support 100 kids again this year, as we did last year. We've been doing this for quite a few years, and quite frankly, they've become pretty dependent on us to help out. So if you haven't had a chance, please think about helping out. But today, we're going to talk about pulmonary emboli, sort of a hot issue, and things of an area that certainly has evolved tremendously over the last several years. And Wissam's going to tell us a little bit about what's going on in the newest strategies, and I presume a little bit about the Emory program that he and Michael and others have helped pilot to further manage these patients with acute PE. Wissam, bring us along. Tell us what's going on.
Thank you. Good morning. I think it was about 3 years ago when I gave this talk. Michael has given several talks also on pulmonary embolism. We started the PE program at Emory in 2011, something around that. Dr. Leeper was still alive at that time. He was very instrumental when it comes to that. Started at Midtown, shifted it to Grady, then came a little bit here. Started doing things with other specialties and brought treatments to the cath lab, did more surgeries and maybe more lytics. Some data has accumulated since then. The field maybe has moved a little bit more in terms of new gadgets and formation of pulmonary embolism teams, although there has been not a huge shift in terms of treatment paradigms. I'm going to give you an update of what's going on in that field and how we've built our team over the last few years. I'll start with a case. This is a 22-year-old female who's 2 weeks post C-section. She had chest pain for 3 days. She came in, she had stable vital signs, doesn't look bad, high D-dimers. Troponin is negative, BNP normal, EKG normal. If you look at her CT scan, these are the central pulmonary arteries. They look clean. If you scroll down a little bit more, you see a small filling defect. That's a small segmental pulmonary embolus. The right ventricle, which is the anterior chamber here, is small. So that's a low-risk pulmonary embolism. You can argue that this patient can even go home on novel anticoagulant. So this patient should probably be treated differently than another patient, for example, this one, who's a 66-year-old female presenting with 2 days of worsening dyspnea on minimal exertion, so she's more symptomatic than the first patient. She has history of hypertension. Blood pressure was also fine when she came in. Her heart rate was okay, saturation okay. Troponin was mildly increased. And by echo, she had a moderate RV enlargement with an RV systolic pressure of 70. If you look at her CT scan, she has more central thrombi, mostly in that right lobe. Now, typically, at least at Midtown and at Grady, we get called on all these patients from the ER. And what happens is that one of us is on call 24/7. And that person gets the call. It's an attending usually at Midtown. At Grady, it's usually a fellow. And we get a call from the ER or from the floor, and we vet the patient, maybe on the phone initially. Then we may go on the computer and look up CT scans, look up numbers. And then, if need be, we convene with the team. And our team is mostly made of vascular medicine, pulmonary ICU specialist, hematologist, interventional cardiologist, and CT surgery. And that's at least at Midtown. At Grady, we also have vascular surgery. In the past, we've played with maybe going on Go Meeting website, reviewing the case online, but we found maybe that the most efficient way is to just send a big text message, trying not to put patient's information in that, so to remain HIPAA compliant. And that's an example of a case that we discussed. You see here 8 people, and there are multiple specialists. One of us is presenting the case and sending CT scans, and if need be, 2 or 3 of us would go on the bedside, especially if we need to do some treatment on the patient. So you want to push lytics or want to send the patient to surgery or want to do catheter therapy. It's not infrequent that, depends on the specialty of whoever is involved, they recommend the specific therapy. So, and especially initially in the experience, maybe the pulmonologist would say, oh, let's just do heparin, and the interventionist will say, let's do catheter therapy, and the surgeon will say, I want to do surgery. But actually, with time, it turned out that we converged to one opinion as we got used to each other, and we got more and more comfortable with what each one of us can offer. Now, back to this lady. In the past, maybe those patients with PE and evidence of RV strain, we used to take them all the time to the cath lab maybe and do catheter therapy, but we became a little more, a little less aggressive. We've all kind of shifted towards a medium of not being too aggressive, not being too conservative on these patients. These times, frequently we try with medical management, especially if they're very stable, not tachycardic, not hypotensive. So we started it on heparin. We actually discussed with her, we can do some catheter therapy, help you feel better, get better quicker. But we started it on heparin, and then 2 days later, she was still very short of breath. We repeated the echo, and her RV systolic pressure now is 90. So we discussed with her again, the team reconvened, and we thought, let's do something. We took her to the cath lab. This is a pulmonary angiogram. You see it is very clear here. This is DSA, and you see how there's a big filling defect in the right interlobar branch. It's occluding both the right middle lobe and the right lower lobe. This is a still picture of it. So we used one of our new catheters with her. This is called Emory catheter. I have a big catheter here, a wire in the branch, injecting here, making sure that I'm distal to the clot. We deployed one of those catheters. I'll just show it a little later in my talk, called FlowTriever, and then pulled some clots out. And these are the clots that we got out of this patient. When we did the pulmonary angiogram, again, you can see how there has been significant improvement in the flow. Now we opened up the right middle and right lower lobe. This is before and after, and she had significant drop of her PA mean pressure in the cath lab. It was 45 and then dropped to 33. She felt better. She felt immediately better. Next day, her RV systolic pressure was 45. RV size was improved, and she went home that next day on oral anticoagulant. So one of these therapies were not available to us several years ago. Before I go further in the talk, I like usually to show this video. Some of you have seen it. It's a video of pulmonary embolectomy. And just to think about what clots, what PEs look like, what big PEs look like, and how difficult it is sometimes to treat these, whether with catheter or whether with just heparin. So it's hard to imagine that that huge clot can be taken out with a small catheter, or that all of it is going to be just resorbed by using heparin. All right, so how do we risk stratify PEs? When we see PEs, when we get called from the ER, the first thing that we think about is this PE causing hemodynamic compromise or not. People with pulmonary embolism do not die from desaturation. What they die from is from hemodynamic collapse, from RV failure. And that's why the RV function is at the center of risk stratification for pulmonary embolism. So a large PE is going to cause an obstruction in the pulmonary circulation, and that's going to cause further desaturation that causes more pulmonary vasoconstriction, leading to a vicious circle. And then a sudden increase in the pulmonary pressure causes RV strain. And that strain clinically is seen as EKG changes, RV enlargement, whether by CT scan or by echocardiogram, increased BNP, increased troponin, and eventually all that leads to cardiocirculatory arrest. So an easy way of stratifying these patients is based on the European guidelines, which is hypotension or no hypotension. That's the main thing when we look at PEs. Is the patient hypotensive or not? Hypotensive shock, meaning the patient is at high risk, we need to be aggressive with their care. Not hypotensive is patient is not high risk. But if we look at those non-hypotensive, we can still stratify them into further groups. We call it submassive PE or low-risk PE if they don't have RV strain. So if you look at this pyramid, most of the pulmonary emboli that we see, 55% of them are low risk. And the definition of that is having no hypotension and having no evidence of RV strain. So there's no hemodynamic compromise associated with this pulmonary embolus. And their mortality is very low. The mortality is typically much less than 1%. At the top of the pyramid, about 5% of patients, and we see those numbers in actually our data, they are defined as hypotensive. In the American guidelines, they're called massive PEs. So when we say massive PE, some people mean big clots, but usually, and based on guidelines, it's actually hypotension. So massive PE is either hypotension or somebody requiring 1 or 2 pressors to maintain the blood pressure or post-arrest, and the mortality is high, is upward of 50%. In between, and it's a continuum of risk, there's a group we call submassive PE, and these are patients that are not hypotensive, but they have evidence of RV strain. And these patients have mortality that's anywhere between, based on the series, and based if you look at hospital mortality or 30-day mortality, anywhere between maybe 3 to 20%. If they have only RV enlargement but normal troponin, they're at lower risk. But if they have both RV enlargement and increased troponin, they're at intermediate to high risk PE. And this is the population that we feel is being undertreated when we just treat them with anticoagulation. Data has shown, and this is one of the studies, that if you have RV enlargement and or if you have increased troponin, your risk of death increases, your mortality increases. And if you have both, so both RV enlargement and high concentration of troponin, your mortality PE associated is increased, and this study is 8.3%. There are other studies showing that if you also have RV enlargement, your risk of developing pulmonary hypertension down the road or of having persistent RV dysfunction is elevated. Another way when we look at these patients of stratifying them is really based on just baseline clinical characteristics. There is a score called Simplified Pecci score that's very easy to remember. And in these parameters, if the patient has any of these, it means the patient is at high risk. But that's not just hemodynamic compromise, that's correlated with inpatient mortality. And these are patients we take more seriously, and we definitely admit them rather than sending them to the observation unit or sending them home. Age more than 80, cancer, history of chronic cardiac or pulmonary disease, pulse rate more than 110, low blood pressure, or arterial desaturation. This is another case of pulmonary embolism. So compare it to the first lady I present, which had very tiny clot in the lung. This is a 50-year-old man with a history of smoking who presents with chest pain and dyspnea. Blood pressure is okay, probably borderline, I would say. Heart rate 114, that's not a good sign. Saturation is okay, 92% on room air. He has sinus tachycardia and non-specific changes by EKG. His troponin is elevated, and typically PE is not going to elevate troponin much higher than that unless the patient arrested, but troponin up in the ones is usually what we see in submassive PEs. BNP is elevated, D-dimer elevated as usual. Echo, RV is moderately enlarged. And if you look at his CT scan, some of the stratification we do is by looking at the CT scan. Here he has more central clots in both lungs. And if you scroll down, you can still see those clots going into the segmental branches, causing obstruction. And we look at the RV on CT scan even before we get an echo. We don't always need an echo to stratify these patients. So the RV looks bigger than the LV, which is a sign of RV strain. And another sign we look at is contrast in the liver. The contrast is given in the upper extremities. If we see contrast refluxing in the liver, it means there's RV strain. It's similar to the reversal of flow by echo. So I want to argue that this patient probably should be treated not just with anticoagulation. Anticoagulation is what guidelines say on this guy, and the treatment typically is, in most of the time, anticoagulation. We feel that this patient may benefit from aggressive anticoagulation, and this patient we usually treat with catheter-directed lytics. Now, the cornerstone of treatment for PE is obviously anticoagulation. So when I say aggressive treatment or different treatment, it does not mean the patient does not get anticoagulation. That's the cornerstone. But there are other aggressive therapies that we should consider on them. Catheter therapy, systemic thrombolysis or surgery. And this is really what we mean by more invasive or aggressive therapy. Why do we consider that? Because the risk of deterioration and death in patients with significant RV strain is elevated. We've seen that. And anticoagulation alone, and it has been shown, takes up to 3 months to resolve the thrombi. And the thrombus resolution may not be complete, leading to chronic pulmonary hypertension and functional limitation in some patients. If we look at how many patients with pulmonary emboli, acute pulmonary emboli, end up having limitation down the road, that's not a trivial number. So far I've spoken about the acute mortality. That's what we worry about in many of these patients. But we also worry about them having functional limitation down the road. If we look at the chronic thromboembolic pulmonary hypertension, which is a dreadful disease, CTEPH, the risk is quite low, especially with first-time PE. Usually happens with recurrent PEs. And the risk is anywhere between 1% and 5%, depending on the studies that you're looking at. But more patients will have some functional limitation. More patients will have measurable limitation in their cardiopulmonary function. And some of these patients will still have residual thrombi and residual occlusions on their CT scans when you do CT scans down the road. We're thinking that maybe, and again, but we don't have a lot of data on that yet, maybe if we're aggressive early on by removing those big clots, we can reduce some of that functional limitation. Let's consider what we have in terms of treatment. So I'm going to go through each therapy and see what we can offer and what data is behind these. When it comes to systemic thrombolysis, if we look at the guidelines, and if you want a good document to go back, is the American Heart Association guidelines published in 2011 by Michael Jaff. The guidelines give the systemic thrombolysis therapy for massive PE. So I'm going to first talk about massive PE, which is hypotension. So somebody coming in with hypotension to the ER or on the floor, 80, blood pressure 70, or CPR. We typically give these people systemic TPA. So TPA, 100 milligrams, that's the typical dose. The guidelines give it a class 2A, evidence B. The reason for that is that there's not a lot of trials on that. If even when we think this is the standard of care, the trials are limited. And that's based on an old study done a long time ago on just 8 patients, 4 of them receiving lyrics and 4 receiving heparin. The 4 receiving heparin died, so it became a standard of care to give TPA for massive PE patients. Now that's not the whole story, because there has been more general studies and sub-studies looking at all patients with PE, but if you do meta-analysis on only the ones that came in with massive PE in the big studies that involved a lot of other PEs, including submassive, it seems that the data points towards reduction, if you give TPA, reduction of recurrent PE or death as a combined endpoint, although we really have never been able to demonstrate reduction in mortality with TPA in any of the studies, but you consistently see that signal or that finding of increased major bleeding on TPA, and that makes sense. So there has always been this pull between saving the patient and between significantly increasing risk of bleeding. There are some registries showing also that for the patients, for all patients with massive PE, this is a big registry of 21,000 patients. If patients receive thrombolytic therapy, they tend to live more than patients who do not receive thrombolytic therapy. This is not randomized data, obviously. This is just registries. But the important thing to draw out of these registries is that even with the therapy that we think saves lives, and even when the mortality is high, we don't use that therapy that often. 30% of patients only are treated with systemic thrombolysis when we think they need it. And the reason is multiple. Some of these have contraindication to lytics, and a lot of times physicians are uncomfortable giving TPA. They're kind of, oh, let's see what the patient's going to do with just heparin. Let's see how pressors are gonna do, and they're worried about bleeding. And the other piece of data is that over the last many years, the risk of mortality in patients receiving lytics is still about the same. So we have not really done big strides when it comes to mortality in patients who come with massive PE. And this is a population that dies. This is much higher mortality than our acute myocardial infarction. Now, this is massive PEs. How about submassive PEs? So how about giving TPA for patients who come in with RV enlargement but normal blood pressure? And this has been more studied just because there are more patients and easier to randomize than the patients with massive PE. And the guidelines give it a recommendation 2B with a level of evidence C. There is data on that. One of the earlier studies is a highly quoted study, Moppet 3, where they randomized patients with submassive PE, again, normotensive with RV strain, to heparin plus alteplase or heparin plus placebo. And we have consistently seen the same outcome in several studies, which is death or escalation of treatment or hemodynamic collapse is reduced when you give somebody TPA. So we know TPA is doing something to these patients, but the mortality is not different. Probably because the risk of bleeding is significantly elevated when you give TPA. The most recent and the biggest study done in this field in patients with submassive PE is the Pease trial that randomized about 1,000 patients to TNK, not TPA this time, TNK with anticoagulation versus anticoagulation alone. And they showed, again, the same thing, which is hemodynamic collapse within 7 days is reduced when you give TPA. Risk of death is maybe less when you give TPA, not statistically significant, but obviously the risk of bleeding is significantly elevated. So major bleeding increased with tenecteplase versus anticoagulation, so that the overall risk of mortality is not changed. So we know that when we give TPA for patients with submassive PE, it helps somehow because it stabilizes them, but it can lead to increased bleeding. There's this meta-analysis, and it's a highly quoted meta-analysis in this field, published a couple, 3 years ago, on all patients who came in with PE and given lytics. And in this meta-analysis, we saw for the first time that there is some statistically significant reduction in mortality in these patients. But look at the number needed to treat is 59, and most of these patients are stable patients. But number needed to harm in terms of major bleeding is 18. Now, if we look at maybe patients who are at less risk for bleeding, so people less than 65 years, their number needed to harm is much higher, and that becomes maybe reasonable to consider. So we consider in general TPA in patients who are at low risk for bleeding, who are maybe on the upper spectrum of risk. It's reasonable to give them systemic TPA. There's some solution maybe in between, and it's not very well studied, which is half-dose TPA. This is one of the studies called Moppet Trial. It's a small single-center study, but it kind of opened the door to the thought of half-dose lytics. So instead of giving 100 milligrams of TPA for these patients that are stable, why don't we give them half the dose, 50 milligrams TPA? And in this study, they showed that there's no significant bleeding, although this is probably not true if you give it to enough patients. Definitely patients can bleed on 50 milligrams of TPA, but the mortality or recurrent PE is less, their hospital stay is less, but importantly, the incidence of pulmonary hypertension, in this study it was really loosely defined. Pulmonary hypertension is not that high usually with PE, but there is a signal that pulmonary hypertension down the road is less. This is an example of a patient that we would give lytics to, 58-year-old man with history of hypertension who presents with presyncope. His blood pressure is borderline, so although by guidelines blood pressure 95 is not massive PE, we know that the guy is at significant risk because his blood pressure is low, he's hypertensive normally. Heart rate elevated, he has no atrial fibrillation, troponin elevated, and by echo, his RV is severely enlarged. That's his CT scan. There's no big central clots, but there's a lot of distal clots, distal thrombi that occlude the segmental branches, and the RV is very big here when compared to the LV. You can argue we can treat this patient with catheter therapy, although the clots are distal, but this is somebody whose risk of bleeding is low. I would definitely consider this patient to systemic TPA, 100 milligrams of TPA over 2 hours, Or if you're a little worried about bleeding, maybe the patient is a little older, low body mass, you can consider 50 milligrams of TPA and see how this patient does. So again, problems with systemic lytics, yes, it's a solution for some of the pulmonary emboli, but it increases risk of bleeding, intracranial bleed, most importantly, between 1 and 5%, and up to 50% of patients have some contraindication to systemic lytics. Most notably, recent surgery. A lot of these patients end up with PE, and then we want to treat them, but they've just had surgery. We cannot give them systemic TPA, and that's where the thought of somewhere in between, which is catheter therapy, comes into play. So the patients that we want to help, we know that TPA helps, but we're giving too much, or maybe we're causing too much harm with it. What if we do something in between? And that's where the idea of catheter-directed therapy came along. What do guidelines say about it? The American Heart Association guidelines give it a level of evidence 2B, and really reserves it, when you kind of read it, reserves it to the higher risk patients. The chest guidelines give it a class 3. They say it's not, patients should not be given catheter therapy because of lack of data. Now, when we talk catheter-directed therapy, most of what's being used over the last several years in the field of pulmonary embolism is really just catheter-directed lytics. That's the most common use that's the most commonly used therapy when we say catheter-directed therapy. And it's usually there are multiple catheters on the market, but you hear about a catheter called Echos, that's the company. But what it is, it's an ultrasound-assisted thrombolysis. The catheter is just a 5 French catheter that goes either through the femoral vein or the jugular vein, and we plug in the catheter inside the clots. And instead of giving the 100 milligrams of TPA, the usual dose is anywhere between 8 to 20 milligrams over, say, 8 to 20 hours. There's no set standard, but in general, it's over several hours that we put patient in the intensive care unit, and we just drip those lytics inside the clot. So the dose is much less, and we think that the risk of bleeding with that is much less. You can infuse that without this ultrasound inside the catheter, but the study done on these catheters was done with the ultrasound assisted. And the ultrasound, and it looks something like that on X-ray. You see the catheter here dug into both lungs, and those dots here represent the ultrasound signals, the ultrasound catheters. And the ultrasound catheter is supposed to loosen the fibrin clot and hasten thrombolysis. This is an example of a saddle pulmonary embolus. This is a patient that came in with borderline blood pressure, significantly elevated or increased RV. This is a central clot. It will look not as bad as that clot I showed you in the video, but will look something like that. So that's a big central clot. You can consider surgery on such a clot, but you can also consider catheter-directed therapy. So these central clots would benefit, especially if the patient is on the higher end of the spectrum of risk, from catheter-based therapy. You see how the RV is very enlarged, compressing the left ventricle, so you know that the risk of this patient is elevated. You know that this patient, if this clot moves or if he or she has any recurrent PE, they probably will die. And this is a case that we've taken to the cath lab. You see here a pulmonary angiogram showing how big the clot is. Notice that the perfusion in the periphery is reduced. And we put a catheter, this is a catheter in it, and it's dripping lytics in this patient over maybe 18 hours. In general, what do we do with these patients afterwards? Do we take them back to the lab, take a look at the lungs? We used to take them back to the lab and shoot a pulmonary angiogram. We became much more selective. Most people don't these days. You just put the catheter. You drip the lytics over, say, 10, 12, 18 hours, and whatever benefit the patient was going to get from the lytics is done by that time, probably. We follow other clinical signs. So if the patient becomes better, or if the pulmonary arterial pressure, which we monitor bedside, is significantly reduced, then we just don't do anything anymore. But if the patient still looks sick, blood pressure borderline, or if the PA pressure remains high, we've taken some of these patients back, and here you see us injecting the lung again. This patient maybe halfway responded. You see the clots are less, but importantly, which we focus on when we do pulmonary angiograms, we look at the perfusion of the peripheral lungs. You see here that there was no perfusion in the upper lobe. There's significantly better perfusion in the left upper lobe. And this patient we typically leave alone. They do fine. This is another case. So catheter-directed therapy, although I'm discussing submassive PEs, we've also used it in massive PEs, especially when they have contraindication to lytics. This is a 72-year-old man who just had a gastric cancer surgery and arrested next day. Patient was too sick really to go for CT scan, so we assumed he has PE. The bedside echo, the RV was enlarged. He had a couple CPRs, and we were called in. We took the patient quickly to the cath lab, and we injected. This is just a manual injection in the lungs. If you have massive PE, just a few cc's of injection will really show the whole thing, because there's no good flow in that lung, and you can see how the whole left pulmonary artery is occluded. You see this dot here in the artery, in the pulmonary artery. That's the tip of the catheter here plugged in, just to demonstrate that it is after the clot and it's dug in the clot. We give a little bolus, maybe 4 milligrams TPA, because the patient was sick, and then we infused lytics over 24 hours in this patient. This case was a couple or 3 years ago. IVC filter placed, that was taken out later. The patient did very well and recovered. So we have used this therapy in patients who have absolute contraindication to lytics, mostly surgery, and they really don't bleed that much. It's a very low dose. Now, what data do we have on this therapy, catheter-directed lytics? The catheter was FDA approved based on a small randomized trial, which is a little surprising, but it's the only randomized trial we have on it, which is called the Ultima trial. It was only on 50 patients that were randomized to catheter-directed lytics or heparin, and they showed that the RV to LV ratio, which is a sign of right ventricular strain, from baseline to 24 hours and to 90 days was reduced when you used the catheter versus when you just used heparin. They also had a registry on the same catheter, 150 patients, a single-arm registry, where they showed that the PA pressure was significantly decreased post-procedure and was maintained at 48 hours. And importantly, they saw no intracranial hemorrhage. So not the signals and signs that we see when we use systemic TPA. When we looked at our data, we also saw that most patients would have a reduction in their PA pressure from baseline to after the catheter-directed lytics. And this is data over several years that we combined with Vanderbilt. When we also looked at complications, so it's important when we're talking to the patients, because we don't have a lot of data on these catheters. What kind of complications are we looking at? The complication rate is low, less than 5%, and most of the complications are just site hematoma or maybe needing transfusion. But the serious complications are very low, so fatal complications and intracranial hemorrhage is low. And importantly, when we did meta-analysis on that, we looked at all the studies. If we look at intracranial bleed, which is obviously the most dreadful complication of TPA, if you look at systemic lytics, it's 1.5%, and this is in everybody. If you take older patients who are high risk for bleeding, it's going to be higher. On heparin, it's 0.2%, but on catheter-directed lytics, it's 0.35%. So somewhere in between, closer to heparin. So we feel that this therapy is safe if we really select the patients and not do it indiscriminately, if we select the high-risk patients. Who in our mind would benefit from catheter-directed lytics? So like I said initially, and in a lot of practices, they would take everybody with submassive PE RV enlargement. I don't think that's right. I think we should take the patients who are at high risk of the spectrum. So if they have significantly enlarged RV, they're symptomatic, they've had syncope. Syncope is one of the bad signs. When patients come with PE, it's associated with increased mortality. Patients with significantly increased troponin. And if they look sick, if they're tachycardic, they're hypoxemic, they look apprehensive, these are the patients that we tend to take to do catheter-directed lytics on them. And in patients with high-risk PE, so massive PE shock with relative contraindication to lytics. How about other catheter embolectomy? So we talked about catheter-directed lytics. How about other catheters? Do we have other options? There has been several described before, and we have used some ourselves. People have described in massive PEs, patients that are not doing well, you want to save them, some balloon to kind of try to macerate the clot, maybe rotating a pigtail around a wire and in the effort to macerate that clot and push it further downstream. In my opinion, I don't think these are very helpful. We've tried them. Probably Michael has tried them too. They're not that helpful when patients are dying when they have massive PE. This is Angiojet that has been used. There are some centers. There's a center in Italy that uses a lot for pulmonary embolism, but there's a black box warning around it because it's associated with hypotension and bradycardia. So what we're left with is some of the newer catheters that have been on the market. And this is one of the catheters that we've worked with, and this is the case that I showed you earlier. It's called Inari Flow Retriever, and that's a 20 French catheter that's delivered up in the lungs. It goes over a wire, obviously, and it has an inner tube that has self-deploying discs that are supposed to engage the clot. And then you pull those discs out. This is a video that shows how it works. And we've done several of our patients this way. The first case that I presented was done with this catheter. So theoretically, you're supposed to engage the clot with those discs that you unsheath. And then you pull the whole thing with manual aspiration from outside the table. And it's supposed to work exactly like this. All right. So there are several of gadgets on the market. Obviously, they don't work like this. They can remove some of the acute clots. And we've removed several different shapes and types of clots with this. This is a more rubbery, chronic-ish clot, and these are more acute clots that we've removed. Clearly, we cannot remove that big snake that I showed in the video before. Another catheter is Penumbra Catheter, Indigo Penumbra, and that's a much smaller catheter, 8 French, that has a little ball here attached to a wire that you move back and forth from outside, and it's attached to the outside to a canister with a pump, and it's literally continuous aspiration. And the idea is you're trying to engage the clot with the catheter and moving that ball with the wire back and forth to try to nibble at the clot and macerate it and aspirate. And eventually you spin the blood that you get in the canister and you get something like this. Again, this is a therapy that may be helpful if you have somebody who's sick, you want to just open up a couple branches, you're not going to be able to remove the bulk of the clots. Another therapy that has been on the market for some time is Ngo Vac embolectomy that was developed initially for the lungs, but most of the time we use it these days for central clots, IVC, SVC, because it's a very stiff catheter. It's very effective. It sucks clots very effectively. It is a 22 French catheter attached to a suction cup at the tip, and it engages the clot, and it has a pump from outside that can have a pumping capacity up to 5 liters per minute. So very strong pumping capacity, and usually we do it under general anesthesia. We've done several of patients, not in the PA because the catheter is too stiff to get it on the PA. Some people have, but what we've done is just central IVC, SVC, RA clots in transit. And it will look something like this. We've done all of them in the OR. We've done one patient with conscious sedation, but most of the time we need TEE to be able to see where the catheter is and how we're removing the clots in the RA. And we need a perfusionist. This is why we've done them in the OR typically. And there's a filter here, and this is one of the chronic clots that we've removed. This is an example of how it looks by angiography. You see here that the catheter is quite stiff. This is one of the cases that I've done. I'm trying to snare the tip of that catheter just to direct it because it's a very stiff catheter that doesn't move around. Now, what are indications for catheter embolectomy? When would we use them and not use catheter-directed lytics? In my mind, I think they're good in massive PE when there's contraindication to lysis or when patient has not improved with lysis. Also maybe in high-risk, non-massive PE as alternative to catheter-directed lysis or surgery, so something that's less risky than giving systemic lytics. But we probably need to wait until these catheters get better in terms of removal of the clots. And maybe in conjunction with catheter lytics, maybe in sicker patients we use these and then we leave some catheters. And we've done that in a couple of our patients. We've done some thrombectomy. There was still a lot of clot burden, a lot of occlusions. We left a couple catheters and dripped lytics overnight in these patients. And all these work best for acute presentation, symptoms only for a few days. We've done it up to about a couple weeks. Any symptoms longer than that typically don't respond that well to those aggressive measures because the clots are old. What are challenges when we're working with these catheters? They're small catheters working against big organized thrombi like I've showed you. And really we're working in a 3D space with poor maneuverability. We understand the coronary circulation, the peripheral circulation, but we don't understand that well the pulmonary circulation. A lot of branching in the lungs. Hard to see. You have to go in 2 planes to be able to tell where your catheter is. And also a risk of complication, although we haven't had a lot of complications going in the lungs if you're very careful. But risk mostly of access, maybe injury to the tricuspid valve on the way up. We have to be very careful there. Perforation. And mostly the major challenge is really the unproven and uncertain benefit. How about pulmonary embolectomy, one of the third aggressive options we've had? Typically, if you look around in terms of studies and in terms of what people think about surgery, is that it really has bad outcomes in patients with PE. And that's true if you're taking patients who have failed everything else. So if you're taking patients who came in with arrest, who've had systemic lytics, and now you're taking them to surgery, obviously the patient is not going to do well. The risk is going to be high. So if you select these patients, if you take those patients with very big central clots, borderline blood pressure, big RV, but you can easily target to take that clot out in total surgically, these patients tend to do well, and at least in our data, in our experience, the mortality is low, and these patients have done well. So in the data from Dr. Latouf and Keeling, the mortality was quite low, and these patients did well when they followed up on them later on. This is for the people who missed my first video. I love to show this just because it's very impressive. This is a pulmonary embolectomy, and that's again that big clot being removed. So again, we leave it for the big central clots. This is a video before and after. I think this is a different patient, but you can see how the RV here before the embolectomy is not happy, is not moving, and after embolectomy is beating much better. So if you're successful at removing the acute obstruction, not in patients who've had symptoms for several weeks, that's different. They need to be bridged. They need some, maybe nitric oxide, some other medications to help with pulmonary vasodilation. But for the acute cases, they do well. This is a case of a young lady. So our experience has led to kind of understand other things. This is a case of a young girl who was sent to us after she arrested. She was given several lytics and she was not doing well. She was on the ventilator, and the CT scan showed large, big proximal thrombi. A lot of these cases sometimes can be seen and thought as thrombi, but people can be mistaken. So this ended up not being clots, and you could kind of tell by hints on CT scan. The patient ended up having a tumor in the PA. It was chondrosarcoma, and she did fine. She got chemotherapy as an outpatient. She was extubated. So by having experience in taking those patients to the OR and doing embolectomies, you can also help other patients that way. Now I want to talk a little bit about setting up the PE program at our center and what we have done in terms of treatment, in terms of data, and where we are. And that's going to be the last part of my talk. When people have thought about setting up an interventional PE program, that's the task that we're faced with. We're the little guy, not the big guy. So the way to think about it is really to set up a pulmonary embolism response team, a multidisciplinary pulmonary embolism response team. Because if we just up to setting up an interventional PE program, that's not different from what has already been done with interventional radiology. It exists. We already know that we can treat patients interventional-wise. But what's different is that we need buy-in and to come in from multiple specialties that believe in such treatment and work as a team to come up with the best treatment for the patient. And if we look at how many specialties and how many people have been involved in this, this is a survey that Michael McDaniel did at the last PERT consortium. There's a national PERT consortium that we meet in every year that started a few years ago at Mass General. And it has several centers, and we're one of the founding members. And when Michael administered that survey, we looked at how many specialists. And if you see that clearly there's a lot of interventional cardiologists, but a lot of pulmonary critical care medicine are involved in that consortium. There's non-interventional people on the consortium that are vascular medicine. CT surgery, obviously, very little. This is probably just Brent Keeling. This is that's our only surgeon on the consortium. But then a lot of other people, other specialties, primary care have been there, nurse practitioners. So it is something that has drawn other specialties, not just the interventionalist. And that's how our approach is that we're not seeing the patients because we want to do some therapy on them. We're not just being called to take the patient to the cath lab. That's not the point. If we look at our data, only a small minority of our patients, we've done something in the cath lab on them. Most of them we just give an opinion. We just see them in the clinic. We just address other issues, anticoagulation, new anticoagulants. We have a hematologist on the team that we discuss with. So it's a really multidisciplinary team. In our case, it has the pulmonologist, the hematologist, CT surgeon, the radiologist. Somebody's on call 24/7. And we really need buy-in from the nursing staff. So we have that at Midtown, we have that at Grady. Hospital administration, other departments, it's ingrained in the ER thinking and the hospital's thinking that the pulmonary embolism team has to be called when there is PE, that they feel like, oh, we have not called the PE team, something is wrong. So we market for that routinely. We frequently call the ER and talk to them, and they love it because they're scared of these high-risk PE patients. They want to bounce off the treatment, of the idea of somebody else. There's a single call. There's always, at Midtown, we found that it's attending driven, make it easier because fellows change every month. No offense to our fellows. All of you, most of you are great, but if all of you are great. But with the changes every month, it's nice to have consistency. And many times we can answer right away. Then if we feel that some patient needs to be seen, we can involve fellows in seeing the patients. We also consult on all patients, so not just on interventional patients. And we've formed so far a virtual PE clinic, so we tend to follow up on all of our patients, and one of us will see them in their clinic, although starting in January, and I have today a meeting to finalize that, we're starting a multidisciplinary PE clinic similar to the heart clinic that we have with thoracic surgeon and a cardiologist together. So we'll have typically a hematologist and a cardiologist or a pulmonologist will be flipping those. We've done a prospective actually data. We looked at our data and we used the numbers that we have to guide us as to how often we need this clinic. We found out that once a month should be enough. We also do routine meeting. We meet every couple months to discuss all the cases, the issues, discuss what trials we have, and we sit down and refine protocols. When we first started, we put these protocols that we have many times deviated from, but they tend to kind of, this is how we've started thinking. And one of the algorithms is in massive PE. If we see intracardiac thrombus, we tend to kind of think surgery, maybe catheter embolectomy. But if the patient has no contraindication to lytics and they're massive, we like to give them systemic lytics. If they're submassive PE, we don't take everybody with submassive PE to the cath lab. We only look at patients at high risk, high troponin, like I mentioned before, or they look sick clinically. And if they have a main PA thrombus very proximal or a thrombus in the heart, then we tend to send them to surgery if they're candidate for surgery. Otherwise, we tend to do catheter therapy on them. With our old algorithm, we used catheter-directed lytics, but now we do other catheter therapy, not just catheter-directed lytics. But with time, we discovered that it's really hard to be this prescriptive when it comes to algorithm. That's where the team comes in. That's where we discuss the cases and see what's best, how best to treat the patient. So when we tried to put that in writing about what algorithm we have for the patients, we really could not come up with a good algorithm of who to treat and when to treat because there's not a lot of data on that. So the best algorithm we came up with is that just the team has to come up with a solution to the patient after discussion, and that includes either medical therapy, catheter-directed therapy, or surgical embolectomy. And most importantly, we put the patients in registry. So we've maintained a prospective registry on our patient, and now we've merged it over the last year with the National Pulmonary Embolism Response Team Consortium that's housed at Mass General. We have so far about a couple thousand patients, and these are the patients that we discuss as a team and we enter in the data, and this would be a good framework for future studies and future trials. We've used our data also for quality purposes. For example, this is just an example of what we've used it for. We discovered that we're very bad at removing filters when we put them in patients. I'm not talking about filters in this talk, that's a separate talk, but when patients do receive filters, before PERT, less than 10% were being retrieved. After PERT, more were being retrieved, but not enough. Seen by PERT members, still not good enough, but higher. When we started doing them in the cath lab, the retrieval rate became more than 90% when we started following up on these patients in our clinic. We have also been able to do studies, trials when it comes to PE. We have been, this FLARE trial is just finished actually on the FlowTriever Inari catheter that I just showed you. We were the #1 academic center recruiters when it comes to recruiting patients for the study. It will be presented in the next big meeting. This is a trial here. Michael has taken a lead on it. Penumbra Trial, the catheter. It's just starting. We're going to be part of the trial. We also try to put every patient that we treat in the cath lab in some sort of a trial. We have started and we've recruited so far a few patients in a PI-initiated study. It's called Sunset PE. It's done at Midtown, Grady, and at University of Pittsburgh in collaboration with them. It's really unfunded. We're doing it ourselves with our coordinators. We're randomizing patients with submassive PE to 2 different catheters, echoes or regular catheter-directed lytics. And in mind, this is to reduce the cost significantly because the echoes catheter is very expensive and that's what's FDA approved. The regular catheter lytics is very cheap and can achieve probably the same thing, but we're trying to study it in a good randomized trial. We're also, as a consortium, we're applying for NIH grant for a bigger study, studying invasive therapy versus just heparin with a good long-term outcome on the patients in terms of 6-minute walk test and echocardiogram. Thank you very much. I'll take questions.
Stay there. That was great. I'll start off with a question. So one thing you sort of alluded to is chronic versus acute, and when do things become too chronic for you to start thinking about invasive techniques? And like I saw, the one woman was 2 months out, and a 2 months history of symptoms. How do you, I guess what's your experience with chronicity, and how do you handle more chronic cases?
Yeah, thank you for the question. So a lot of these chronic cases, when they see us, when they come to the hospital, they typically have sudden worsening in their symptoms. So a lot of these have recurrent PEs when they're chronic, and some of that is acute. So we tend to be aggressive in these. So actually, we do want to do something on them when they have already pulmonary hypertension, when they have big clot burden, and we are frequently able to remove some of the acute clots. Some of the chronics continue to be there. If they come to us saying, over the last 2 months, I have not felt good, and with that sudden worsening, we're typically unable to do much. The CT scan is very helpful because sometimes you could tell that some of that clot looks kind of looser, looks more chronic, and we have tried to go in with catheters with variable success, but in general the success rate is significantly reduced when you have somebody chronic. So it's not like we absolutely do not treat them aggressively. We try to, but we keep an eye on these patients because some of them we've eventually sent to a big surgery with endarterectomy. We've done some low-risk endarterectomies here. We've sent some to San Diego for treatment. San Diego has the biggest experience in terms of endarterectomy for chronic thromboembolic pulmonary hypertension. It's a different beast, and the presentation is different for patients. Frequently, those patients have long symptoms, multiple PEs in the past, although some of them present acutely now, but they've had a lot of undiagnosed PEs in the past. They're different category. Most of what we focused on, and actually this is what the 99% of the patients we see, are patients who come acutely without prior pulmonary emboli.
Wissam, if you could comment a little bit on how all of this got started. I don't think this was a situation where Emory Healthcare came to you and your team and said, we absolutely have to have a PE program. This was sort of a grassroots effort, I believe. And then just another comment is that as we go into team-based approaches and processes, we've done this with acute MI. Those are things that are sometimes easier to implement when it's patient coming into the emergency department. And then going into a system, how do you approach this from the standpoint of you've got all these patients in the hospital and appropriate recognition and that type of thing? How do we get others educated around that? That's the real challenge.
Very important and difficult questions. The first question is how it started. We were lucky, I would say. It's good when something is started as a program. It's good to have multiple people excited about a topic. Now you clearly need at least one, and better if you have two champions who want to push the field. And it did start without. You're right. It started. Nobody came to us and said you need to start a PE program. It was just something that Leaper and that was the advantage that we have Kenneth Leeper, who believed strongly about treatment of PE and being more aggressive with treatment of PE. It helped that I had just started and I was not that busy, so that's helpful always. But in general, you need people who are very excited, who want to advance some field, and then they amass people around them. You need a lot of meetings. When we started, Michael McDaniel was with us at the beginning. Henry was also with us, Lieberman. And we were meeting frequently. So we're meeting maybe once a month, sometimes once a week, to start thinking about it and starting writing protocols and implementing and how to implement it. So it's really a lot of efforts. These are not simple things. They're not say, I want to start this program and just write and send emails to people to start it. It took us about a year of meetings and preparations and for people to start hearing about it. And then we met frequently. We gave talks. We met with the ER, and importantly, we involved the ER also from the beginning. We involved radiology. We involved all these specialties to feel that they have ownership of that. It's not just you. It's very hard. That's why I drew that. I showed that picture of the little guy with the big guy. There's a lot of institutional culture that you need to get over. So this is why you need multiple specialties and buy-in from multiple people, and a lot of meetings, a lot of talks and frequent reminders. And initially we're not getting a lot of calls, but with time, when you talk to them, when you show them what you've done, when you frequently meet with them, so frequent meetings, frequent talks is very helpful when it comes to that. Michael, you wanted to comment on that, is that right? Do you want to comment from your end, from Grady?
I was just going to say also, take Dr. Lattouf had a lot of the already being a lot of referrals in from outside too. So taking that backbone too to use the networks that people have already been referring into was another.
That's true. He was done. I'm sorry, I forgot to mention Dr. Lattouf also as one of the energetic people at the beginning who had experience and wanted to push that forward. The second question is about multidisciplinary team. I think one of the funnest thing in this PE program is this multidisciplinary facet of it. Is you learn a lot by just sitting with other specialties. You learn from them, they learn from you. And I think this is how we should address a lot of the issues we have right now. And to form a multidisciplinary team, multidisciplinary clinic is very helpful for the patients. There has to be presence of this team. For example, here at EUH, I don't believe we get a lot of calls when it comes to pulmonary embolism. It's just because maybe there hasn't been that push from multiple specialties. There hasn't been these routine meetings of multiple specialists sitting together and forming a clinic and all coming on the same conclusion. And it doesn't have to be that the pulmonologist who's going to come on the team believes in aggressive therapy. This is not about being an interventional program. This is about all coming together to help the patients. It could be a team that's very conservative, that's mostly treating patients conservatively, but at least learning from the experience and having the framework to gather the data and to do trials on these patients. And that's why I do believe now, we've started initially doing a lot of therapies that are not in trials. But I believe now that every patient that we take to the cath lab, because we don't have a lot of data, we have to put them in some sort of a study, and that's what we're doing right now. Every patient is screened and approached to get in one of the trials.
One last one. Wissam, very nice presentation. It's been a challenge at EUH because the chest, when they have the class 3 recommendation, the pulmonologists come back always to us and say, you guys are doing something which is not approved. So it is extremely challenging for me. Question about, are you thinking of chasing the DVTs in the iliofemoral region with catheter-directed lysis? Because that's where this thing many times originate. And the post-phlebitic syndrome, it's a tremendous toll on the patients when those things are not lysed.
For the DVTs, it's working with the PE opens usually the door to all these venous cases, which are a little messy. Now the data, there's a recent study on the TRACT study that showed no benefit from lytics in acute IVC clots. That dampened the enthusiasm a lot about treating these clots invasively, but we still see patients who come in with bad legs or bad arms with significant proximal thrombi that do not respond to heparin, and they still have a lot of edema. And these patients, we tend to be sometimes aggressive putting lytics, but we're conservative when it comes to that, when it comes to the iliac veins. Do you see anything different in your practice? Do you do a lot of...
No, we are not because of the marketing. And the problem is if you don't take these patients within the first 2 weeks, the success rate of keeping these veins patent goes down tremendously. Some people have pushed the envelope till 28 days. But I personally believe after 14 days, it's a very futile effort to try to recanalize these veins.
True, and the problem, Khusro, is that even if you take them, the therapies we have are not great. So you do catheter-directed therapy, there's still a lot of clots, and frequently when you take these acute patients, you end up putting stents in the proximal iliac. So you end up with stents down the road from May-Thurner or something like that. And these are not very clean kind of treatment therapies, but you're right. Doing actually PE opens the door to those acute DVT. But we do get a lot of calls on these DVT patients. We tend to be conservative, but we have treated some of them.
Can I make just one comment real quick about the class 3-2 and the CHEST guidelines? Just so if anybody ever does bring that up to you, it's based on a study from 1988 with like about 30 patients in it, where they basically just blasted full dose TPA in a catheter in the pulmonary arteries and compared it to systemic. So in no way does it represent what we do today, and so I think it's actually been a misrepresentation of the CHEST guidelines. And so just when people are talking about that use of that class 3 for catheter therapies, it's really citing an outdated old study that does not represent contemporary practice. So just as you talk about this, and that the final comment I just wanted to make is that the Pulmonary Embolism Response Team Consortium is a great way for people, if you have any interest in PE, we're really looking for more and more people to be involved in it. There's monthly meetings, there's multiple different groups, there's protocol committee, research committee, education committee, lots of different opportunities to get involved on the ground floor of a grassroots organization. So we need, Emory and Grady are both, founding members of this, so there's a lot of opportunity and we're looking for, help. So if anybody has interest, please reach out to us.
Thanks, Mark.
Thanks very much for a great talk, and congratulations on a great program, and hope everyone has good Thanksgiving.
The preceding program is copyrighted by Emory University.